We have a very intense day to cover today. We've got 3 medium to small joints. Got the wrist, foot, ankle, and toe, and the elbow. So I'd like to start out with a brief discussion of some special projections related to the wrist. First special projection, radial ulnar instability. The only way to diagnose radial instability, besides a physical examination, which, by the way, is probably not as reliable as imaging, is to scan the patient with CT or MRI in full supination and full pronation and look at the radial ulnar excursion on both sides. Very simple. For scaphoid imaging, completely different animal. If you are looking at scapholunate interval disease, I suggest you radial and ulnar deviate the wrist in a direct coronal. You do not need to do an arthrogram. The pickup rate for scapholunate tears on MRI is 98%. For lunato-triquetral tears, not so much. Pickup rate, 82%. So if you do an MR looking for LT failure and it's negative, then you should do the arthrogram. But that's an exceptional circumstance. This one was done with contrast, and you can see how the contrast has come into the space on ulnar deviation, but the diagnosis was obvious without and with. Here's an example of a supinated wrist and a pronated wrist. Usually in the supinated scenario, with radial ulnar instability, the ulnar will drift dorsally. But it's much more helpful to have both sides. In fact, if you're dealing with a hand surgeon, they will absolutely insist that you have both wrists. So you might as well just do it. Let's skip over this and focus on this. If you don't do this, they know you're not an MSK radiologist. Now, maybe you're not, but you know what? You can fake it. There's nothing wrong with that. And your knowledge base will continue to increase. So what do they want for the scaphoid? Perfectly parallel imaging to the long axis, so that it looks eventually like this. So how do we get there? Let's show you how we get there with CT. So here's a CT. It was acquired orthogonally, reconstructed coronally. So then we take our coronal that we've reconstructed and we do an oblique down the long axis of the scaphoid, evaluating the integrity of healing and our compression modified Herbert screw. Then we take that, which we've just created from this, and we make another oblique. So this is a paraxial, this is a parasagittal off the paraxial. So let's go back. Axial acquisition, coronal reconstruction, axial oblique, sagittal oblique, and now you have your sagittal oblique. One more left to go. And look at how well we're seeing the entirety of the Herbert screw, the entirety of the scaphoid, the character of the union. And then finally, we're finished. The last oblique. Now, I don't know what to call this. A compound, paraaxial, parasagittal, paracoronal. But that's how you get there. This is what they want in the final analysis. Is this how we do our MRIs? You bet it is. Especially if we are looking at AVN and the character of bridging. But most of the time, when we're after pure bridging, CT wins, hands down.
50-year-old female, pain progressively worsening after a fall.
So my approach to the wrist, I usually put up all the coronals first, no matter what the diagnosis, with two exceptions. Tunnel syndrome, masses, maybe loose bodies. Otherwise, coronal first. I feel guilty saying that because it sounds like Trump saying America first. Doesn't sound very good. On the left, T1. In the middle, PD spur. And on the right, GRE. Anatomy, detection, articular, tendon ligaments. I'm going to give you my approach in a moment, so I'm not going to take you all the way through the approach. Just want to introduce this case because of the special sequences. First glance, it doesn't look like there's anything wrong, does it? TFC looks good. SL ligament looks good. LT ligament looks good. But there is one finding. Give you 5 seconds to reflect on the finding. There's too much fluid in the distal radioulnar joint. What do I allow? Millimeter of width. And some cartilage on either side. Look very carefully. Erosion. Okay. Now it's time to go short axis. Patient is in the neutral position. There's unexplained fluid in the radioulnar joint. The ulnar is a little short compared to the radius. We'll discuss that later. But in the neutral position, don't you think the ulnar is riding a little high? Let's look at the sagittal. The sagittal, we have alignment between the third metacarpal, the capitate, the lunate, and the radius. What about the ulna? Little dorsal, huh? How many times have you missed this on a lateral x-ray? Many. I know I have. But this is a very debilitating injury, if not dealt with early on. Because once you develop radioulnar arthritis, game over. So where is the radioulnar view? Came later. We brought the patient back and did steep pronation, steep supination views, and there was radioulnar instability. You'll see it later, but that's no matter. We compared the two sides, and there was much more excursion in the right wrist than the left. Now, why does this happen? We see it more frequently in negative variants, and look at the volar radioulnar ligament. Look at how thick and fat and fibrotic it is from chronic injury. So this is a case that illustrates the value of understanding how to proceed with special sequences. I had the patient come in, rule out radioulnar instability, we would have automatically done pronation and supination views. Unfortunately, they just did a routine wrist MRI. Okay, let's go back now and give you a little wrist introduction. Okay, so I'm going to approach the wrist by projection. Most favored nation status, the coronal projection. So that's your projection for the TFC, the scaphoid fossa of the radius, scapholunate advanced collapse or slack wrist, the skeleton, fractures, the first CMC, the intrinsic scapholunate and lunatotriquetral ligaments, the oft elusive, ignored extrinsics, but no more. We're not going to ignore them anymore. We're going to look for the volar radioscapho capitate ligament, the radiolunate ligament, the dorsal intercarpal ligament, and the long radiolunate ligament. Axially, my second favorite projection. For tunnels, carpal tunnel and the syndrome of Guillen's canal. Os styloideum. You saw yesterday how valuable it was for pulleys, flexors, extensors, although the sagittal, #1 for retraction. Lister's tubercle. Anomalies of Lister's tubercle, fractures of Lister's tubercle. First move, EPL status, extensor compartment #3. Masses, fractures of the hook of the hamulus, radial ulnar joint, supination, pronation. And yesterday you saw distal intersection syndrome, where scar tissue caused contractile friction between the EPL and the extensor carpi mechanism, one being partially torn, the other being ruptured. Some basic angles. You know I don't like to measure. So I'm going to give you something pretty quick to do. So typically, you will see people do this on an X-ray. Say this is the lunate. I'm drawing it in. So this would be the axis of the lunate. This would be the axis of, the long axis of the scaphoid. Right there, agreed? So this angle is about 30 to 60 degrees. If the lunate starts to rotate down, then that angle will decrease. Sorry, if the lunate starts to tilt or rotate forward, that angle will alter. If the lunate tilts back, that angle will alter. And I will show you how it alters in a moment. But let's do something even more simple than that. I'll simply look at the overall axis of the scaphoid relative to everything else. And I like to see it about 45 degrees. So if it's standing up, it's a problem. If it's lying down, it's a problem. That's easy. Then the other thing I do is I look at the position of the lunate relative to the radius. So let's do that. I don't mind the lunate tilting forward. Sorry. I don't mind the lunate tilting forward a little bit, as long as I don't have other supplementary signs of instability. When it tilts forward too much, VISI, volar intercalary segmental instability. When it tilts backward with the appropriate other signs, then I would consider DISI, dorsal intercalary segmental instability. But there's more. What if everything's lined up properly? The capitate is centered over the radius, but the lunate is displaced. Not tilted, displaced. It could be tilted, but also displaced. That's a lunate dislocation. What if the capitate has gone dorsally, but the lunate stays? That's a perilunate dislocation. That's plain radiographic stuff, but some of you are not MSK radiologists. So we've got VISI, DISI, lunate dislocation, perilunate dislocation. And then we've got the 45-degree angle of the scaphoid, which can alter if there is rotatory instability of the scaphoid. Let's go back now. So this is here as a reference. I didn't talk about it yesterday because I didn't want to scare the daylights out of you. But when you have soft tissue and flexor and extensor injuries, they are characterized by bone or no bone, where they come off of, and what zone they retract to. So you have flexor zones, and you're going to have extensor zones. These are all on MRI Online with an explanation of the meaning of each. For instance, some extensor retractile injuries are prone to osteomyelitis and infectious septic arthritis. And you'll learn about each one of these. This would be a 3-hour discussion, not a great use of our time, but you'll have it on MRI Online as a reference, zone by zone by zone. We'll take each zone, DP3, 2 minutes, DPT, 2 minutes, so that you can walk around, take a look, and learn it over time. I've got a nice piece of anatomy here. It's a coronal. I love the coronal. It's an arthrogram, and it demonstrates not so much the anatomy, even though the anatomy is gorgeous, but the technique. The in-plane resolution is awesome. Right? The field of view is 7, ideal. For finger, 4. How high? 10 or 12. Going much above 12, probably not getting good enough resolution. So look at the radial collateral ligament, the scapholunate ligament, the oft perforated, normally fibrillated LT ligament. Yes, there is an abnormality, but I am showing it for the quality of the image. Now, in small parts, I find even more value in the additive gradient echo image and steady-state free precession, the very heavily water-weighted arthrographic-like sequences. So steady-state free precession, also called steady-state free precession or Fiesta, adage, a gradient echo, also known as adage, MFFE, merge, medic. Now in the wrist, I really insist on 3Ds if I can get them. So we've got 1.3 millimeter slices here. That way you'll be able to tease out scapholunate and lunato-triquetral ligaments with no problem. So 3D GRE or 3D SSFP, particularly in the coronal projection. A couple of other basic points. All of you did residencies in something. Remember the arcs of Galula? Well, we use those on MRI. We have arc 1, base of the proximal row, arc 2, concavity of the proximal row, arc 3, convexity of the middle row. And we're going to look at that alignment, especially in individuals that have intrinsic ligament failure, scapholunate or lunato-triquetral failure. Not going to spend much time on the axial anatomy. We yesterday talked about compartments 1, 2, 3, 4, 5, and 6. We gave you origins, we gave you insertions, we gave you the significance of each. Caveat: these two may be septated from one another. Caveat: this little one right here, frequently multiple slips. How many? 20. So what does 20 slips look like? 20 slips looks like this. So you're going to call that tendinitis or tendinopathy every time, unless you see a hole, a gap, a transection, peritendinitis, interstitial actual edema. Do not call that a tear, because somebody will get an operation. How do I know? It's the last case I defended a radiologist in court on. Then we get a little more distal to the level of carpal tunnel, anatomy coming to a theater near you. The median nerve usually sits superficially. Sometimes it'll sit between the FPL and the flexor indicis over here, the so-called vertical median nerve. We've got a proximal tunnel at the pisiform, we've got a distal tunnel at the hamate. Sagittally, we'll focus on the angles. Again, I don't measure them, but visually you can figure them out very quickly. And the central column alignment, third, capitate, lunate, radius, tilting, no tilting. TFC. It's a little bit complicated. Actually, that's a lie. It's a lot complicated. So here is an electron micrograph of the TFC. It does not attach to the radius. It attaches to the radial cartilage. So there will be a little high signal defect right at the cortical junction. That's normal. It matches the signal of hyaline cartilage. If you don't know what the signal of hyaline cartilage is today, my advice to you is to go home and start drinking heavily. So we've got cartilage on the ulna. We've got cartilage on the lunate. And all of these structures come into play in ulno-lunate abutment syndrome. Now, things get a little bit complex out here. The TFC does a deep dive. On the inside is some very vascular tissue called the ligamentum cruentum. It is the central portion of the foveal attachment of the TFC. In front of that, volar radial ulnar ligament. Behind it, dorsal radial ulnar ligament. Not completely seen, but partially seen, are the styloidal attachments, which are fan-shaped. There's one of them there. The other one's covered up by a circle. But we also have attachments anterior and posterior, distal and proximal. But fortunately, they are matching sets. So we're going to have a matching set in the front and a matching set on the back. And more on that when we get into the sagittal projection and talk about the TFC. These are known as the set of volar and dorsal ulnocarpal ligaments. So in the front, what would these ligaments attach to? The volar radial ulnar ligament. In the back, what would they attach to? The dorsal radial ulnar ligament. What about out here? Out here, we've got a band known as the lateral lunate ligament. It is also known as the triquetral portion of the ulnocarpal ligament. Don't worry about the name. Just remember there's a band there. And what does that attach to? Some tissue called the meniscus homologue. What is it? Well, whoever made the wrist didn't know what to do with that space. So they just colored it in with some cartilage-like fibrotic material. And the amount of that material varies greatly. So it's a filler. Nobody actually knows what it does. The MH, the meniscus homologue. This is all homologue tissue merging with the lateral lunate ligament. Next section over is going to be the capsule, which you can't see very well, and the extensor carpi ulnaris subsheath, which you can't see very well on this micrograph, and then the ECU, and then the retinaculum. So let's do it again. TFC, ligamentum cruentum foveal attachment, styloidal attachment, ulnocarpal ligament, homologue, more homologue, buried in here, capsule and subsheath, ECU, over the top, more subsheath, extensor retinaculum. This is a slide, short axis, showing that there are volar and dorsal attachments. Now they happen to go across from medial to lateral. They have different names. There's either 2 or 3 volar ones and 2 or 3 palmar ones. Probably the most important is the most ulnar of them all, the ulnotriquetral ligament. So you're going to have a volar ulnar triquetral ligament, and it goes to the volar radial ligament. There it is. There's the volar radial ligament. Here is the ligament going towards it, merging together. There's the TFC. Then you're going to have a dorsal condensation, known as the dorsal ulnar triquetral ligament. So 2 or 3 in the front, 2 or 3 in the back. We're going to simplify it, though, so it's not so scary when we look at some sagittal TFC pathology. Last one. Here's a high-resolution view of the TFC. It looks like a little cup. This high signal is cartilage. It's normal. Cartilage, capsule, and synovium, normal. Cartilage, capsule, can't see much synovium, normal. LT ligament. Foveal attachment with vascularized ligamentum cruentum, because sprains of that vascular structure produce synovitis. And what's the treatment for synovitis? Steroids, injectable steroids, debridement. Patients do pretty well, as long as they don't have a cartilage defect. Here's the ulnar styloid, a little styloidal recess. Sometimes it communicates, sometimes not. And there is our very vascular high signal, ligamentum cruentum, which you know as the central portion of the foveal attachment of the TFC. Don't believe me that there are ulnocarpal ligaments? Here's one right here. Here's an ulnocarpal ligament going to the LT ligament. They are affectionately named ulnolunate ligament, not seen, ulnocarpal ligament, seen, and ulnotriquetral ligament, previously seen. Here's a simple sagittal drawing, modified and adopted from the esteemed musculoskeletal radiologist Phoebe Kaplan. Very nice, simple arthrographic view and diagrams. But my only intention here is to show you the anchors in the front and in the back. Anchored in the back to the dorsal radial ligament, right there. Anchored in the front to the palmar radial ligament, right there. So you're tethered front to back, you're tethered proximally, you're tethered to the ulnar side, and you're even tethered distally. The intrinsics. Now, when I put up a coronal, one of the first things I do, besides looking at bone shape, conformity, relationships, angles, is I look at things that are commonly abnormal that they're interested in, like TFC, TFCC, abutment syndrome, variance, SL ligament, LT ligament. That's my first 10-second dive onto any series of coronals. I'm not going to miss a fracture. It's too easy. The SL ligament has length from anterior to posterior, just like the rotator cuff has length. So we're going to have a volar portion, a dorsal portion, and a middle portion. Sometimes it looks like a band. Sometimes it looks like a triangle. Sometimes it looks like a trapezoid. As long as it's continuous and I don't see arthritis and fluid and spreading, I'm fine. I heavily rely on the indirect signs of instability to diagnose partial tears. Stretching, membranous perforations. So if I see a pristine, smooth joint and some signal in the SL ligament, I don't care. There's nothing wrong. The same thing is true in the LT area as well. I rely heavily on the secondary signs. And only 1 in 5 cases do I ever need an arthrogram to see an LT ligament tear. I never need it for the SL ligament. Now, the strongest and most stabilizing of the SL ligaments is the dorsal band. So here is your triangular fibrocartilage, and now we have the LT ligament. The LT ligament also has some variable shapes. In fact, more variable than the SL ligament. SL, band, trapezoid, triangle. On the LT side, sometimes it looks like Salvador Dali's mustache. He clipped his mustache. He's got a big mustache. He's trimmed his mustache. He almost does not have a mustache. It's eccentric. All of those are normal. Okay, now I'd like to turn my attention, and by the way, this is just showing a little bit of signal in the LT ligament. But look at the joint. It's perfect. Capsular reflection, slit. Cartilage, perfect. Some signal in the LT ligament, don't care. Normal. Let's talk about the oft ignored extrinsics. It's like the posteromedial corner. Everybody ignored it. So here's one way to think about the extrinsics without getting crazy. On the dorsal side of the wrist, they make like a horizontal V. On the palmar side of the wrist, they make an inverted V. We're going to focus on two main extrinsics in the back and two main extrinsics in the front. The ones in the back are going to include the intercarpal dorsal ligament, which is pretty horizontal, and the lunato-triquetral long ligament in the back. That's going to make your sort of horizontal V. What about your vertical V, your inverted V? This is on the volar side. I'm interested in really two major ligaments. As you get more sophisticated, you can learn all these other short, strong ligaments, but the ones that are most interesting are the ones that are weak, that are prone to tear. So for now, I just want you to learn two in the back, two in the front. Two in the front, one you know well. Remember the radioscaphocapitate ligament or sling ligament? That's it. That's the one that prevents rotatory subluxation, the scaphoid. Now, why is that important? You're tootling along and you see a little fracture right here of the tip of the radial styloid. You have now just destabilized the scaphoid. I bet 50% of you in the room never thought of that. And hopefully it heals back. It's casted. But if it doesn't heal, you've got an instability problem. So anytime you have a radial fracture, you go right to this ligament, right there. The second part of the V, I don't care so much about the ulnar side. On the radial side, I've got a very long ligament which has three different names. Don't memorize the names. All you need to know is it goes from the radius across the lunate to the triquetrum. So that makes it easiest to use the name radio-lunato-triquetral ligament. It also has a name called the long lunate ligament, volar portion. Don't worry about that. Just name it by where it goes. It goes all the way across. Those are the two. Now the configuration along the volar aspect of the wrist is a little more complicated than that, and I don't really care. There are these long ligaments, and here's that other long one. So this is the volar aspect of the wrist. This would be a radioscaphocapitate ligament. This would be your radio-lunato-triquetral ligament. Then there happen to be some short inverted V's that you're going to see with high resolution. Don't pay much attention to those right now. So you have another little baby V. The only reason that's important is in this location right here. There is a weakness of the capsule that is non-ligamentous supported. So in certain complex instabilities, the capitate is going to come down and anterior, forward. When it does that, it encroaches on palmar structures. This is called the space of Poirier. Okay, let's go. That's fun stuff.
39-year-old male, pinching pain, history of broken finger, and surgery.
Okay, I'm going to do what I always do. Put up the coronals, but if I was by myself and I thought there was a mass, I'd go axial. There's no history of a mass. Broken finger, impact injury, pins removed, swelling, weakness. Evaluate TFCC, complex tear or ganglion. Okay. Patient's 31, I believe. 39, sorry. LT ligament, cartilage, 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 signal, gradient echo, ill-defined, central, not vertical, not bright, not complex, normal. Let's keep looking, shall we? Ooh, that's gorgeous. That is one of the ulnar carpal ligaments. That's going to the LT ligament, also known as the middle ulnar carpal ligament. You don't have to memorize it. There's the lateral lunate ligament going to the homolog. There's the subsheath, which means we ought to run into the ECU pretty soon. There it is. There's the ECU. There's more of the subsheath. There's the superficial retinaculum, which receives fibers from the ulnar styloid called the linea jugata. Great. Foveal attachment, ligamentum cruentum. Styloidal attachment, a little hard to see because the patient is rotated. So TFC, despite their worst fears, is normal. SL ligament, it's a pretty triangle. The joint space is perfect. The cartilage is perfect. It's normal. So far, we're not coming up with a lot. Better change projections. On the far left, T1 anatomy. In the middle, T2. On the far right, PD spur. And while you're scrolling, they were worried about a ganglion. There is one. The two most common positions for a ganglion are directly over the scapholunate capsule. There's probably one right there. A ganglion is simply diffusion of proteinaceous material from the joint through the capsule. It goes through the meniscus. It's a parameniscal pseudocyst. If it goes through the capsule, it's a ganglion pseudocyst. Exactly the same pathology. Second most common place for a ganglion in the wrist, right here. Near the base of the radioscaphocapitate ligament and long radiolunato-triquetral ligament. And you'll see these asymptomatically, occasionally symptomatically, all the time. That's not her problem. Yeah, they were worried about a ganglion. We found a couple of ganglia, big deal. We'll put it in the body of the report. Incidentally noted, volar radial carpal ganglion, dorsal carpal ganglion in the typical locale. We will describe the extensive peritendinitis, no problem, going in the body of the report. But we have a dominant abnormality. That's going in the conclusion. So while you are debating the etiology and histology of this lesion. Some of you who are more experienced might have noticed the patient has an anomaly. That anomaly is a deep, vertical, bifid median nerve. The median nerve, 75% of the time, sits here. 25% of the time, it sits between the FPL and the other flexor tendons. So this is one of those 25%, but it's also duplicated. It's a bifid nerve. Okay, now it's time to bite the bullet. I'm not going to put the sagittal up. I don't think it adds a tremendous amount. Let's put up the contrast study. Well, they put contrast in the joint. Why? Because they wanted it. It adds absolutely nothing to the case. So the signal intensity of our lesion, intermediate to low, agreed? Quite low on T2. So what is the differential diagnosis of low signal on T2? Before we do that, do you think it is aggressive or non-aggressive? First decision. Boundary crossing, invasion. Yes or no? I vote no. Big, but not invasive. So then we go to signal. It's not black signal, lossless black signal like air, like flow, like gas, like metal. Those are out. So what are we left with? Fibrous tissue, blood, siderosis. So she hasn't had an acute bout of trauma. There's not a lot of swelling present. So a hematoma is a pretty unlikely consideration. There's also not a lot of methemoglobin staining. So that really leaves us with only one choice. Giant cell tumor of tendon sheath, GCTS. And that's how you come to the diagnosis. You might say, well, what about a fibroma? They're very rare. They're also very well encapsulated unless it's one of the more aggressive varieties. It's too respectful to be a fibrosarcoma. She's the wrong age and it's the wrong location for fibromatosis. When you get fibromatosis in the hand, what's it called? Dupuytren's contracture. When you get it in the foot, it's called Lederhauser's disease. So fibromatosis isn't a good choice either. Nodular fasciitis, also known as nodular fibrosarcomatous fasciitis. Likes the forearm, doesn't like the dorsum of the hand. So giant cell tumor of tendon sheath. It's extraarticular PVNS. Synonyms include histiocytoma, benign synovioma. There is some debate as to whether this represents a neoplasm, but the majority of pathologists have now accepted it as a World Health Organization grade 1 neoplasm. But it is locally invasive at times and can go into bone. It has been characterized by most pathologists as a fibrohistiocytic tumor. It most commonly likes the DIP region of the fingers. It also likes the thumb. It is frequently low in signal intensity, and sometimes you will see a combination of both siderotic staining on gradient echo and T1 methemoglobin staining on T1. It's usually seen in about 40-year-olds. Satellite lesions are common. This is a radiographic diagnosis. The first response is, okay, let's get a piece of it. Wrong. You'll seed them. You don't want to biopsy this lesion. You want to excise it. Or you might want to leave it alone. GCTS, dorsum of the hand, TFC normal. Median nerve, anomalous, bifid. Shall we look at another? That's a fun one.
16-year-old male, sharp aching pain since hockey injury 2 weeks ago. Fracture 2 years ago.
Okay, unless it's tunnel syndrome, loose bodies, a mass, going straight coronal. Let's do it. T1, anatomy, spin echo on the left. Perhaps you might have thought about scapholunate widening, but in children, big ligaments, big cartilage, bigger space. In the middle, this is a T2, I believe. The SL ligament is perfect. On the gradient, SL ligament perfect. So the abnormality is obvious. It's in the distal pole of the scaphoid. So what are we going to call it? Are we going to call it a fracture, a contusion, a microfracture, other? Let's have a look sagittally. Did they do at this outside location the long axis scaphoid views? Would have been nice. Well, they did at least one long axis view. They didn't do the full complement of obliques, but they made a good attempt at it. I think coronally you might have struggled a little bit as to whether it was a completed fracture, but not on the sagittal. It is a completed waist fracture. So I don't have any problem utilizing CT in the extremities of children. I do have a problem using it in the trunk of children. So the hockey injury was on 10/22. So October 22nd, we are now 6 weeks out. I mean, at 6 to 8 weeks in a young person, don't you think you'd have some bridging? Now, it's too early. What's the cutoff for absolute non-union? 16 weeks. When should you have bridging? 8 weeks. I told you my son bridged a displaced clavicular fracture in 3.5 weeks. So I already know that the odds of this coming back together are low. It's going to end up as a fibrous malunion or as a non-union. So how would I word it? Completed scaphoid waist fracture without rotatory instability, with mild gapping, no angulation, minimal displacement. The appearance of high signal intensity on water-weighted images at 6 to 7 weeks post-injury raises suspicion and high risk for delayed malunion or potential future non-union. Why is that helpful? So then the clinician goes back to the patient, mom and dad, and said, you know what? I think Johnny's going to need an operation with a compression screw. Shall we do another? Long axis parallel views, critical for scaphoid evaluation.
55-year-old female, anterior right wrist mass for 1 to 2 years, increasing in size.
So this time, anterior right wrist mass. I'm working alone. I'm working with one of my fellows. I put up the axials because it's a mass. Why do I like axials? Because I'm a classically trained radiologist and I'm used to cross-sectional imaging first. There are a number of extraneous interesting findings, like swelling of the dorsal radial ulnar ligament. It's not what we were asked to pursue. Take your time. It's an obvious mass. I'm going to put up one long axis. Within the lunate is a large, round, cystic lesion. Statistically, what's most likely? Intraosseous ganglion. Often asymptomatic, often friction-induced. The patient also has a central 1/3 TFC perforation, fenestration, or tear. Probably not symptomatic, not very swollen. We classify our traumatic tears according to the landmark paper of Palmer. So the traumatic classification is going to be 1, and then we're going to have A. A is central, B is peripheral, C is attachment, and D is radial-sided. And you almost never get a radial-sided detachment. In other words, this almost never comes off here. So do not call this a radial-sided tear. Call it a central perforation or fenestration. That is 90% of all traumatic tears of the TFC, maybe 80. The other 15, peripheral attachment tears. And then the others are very rare. We also have another grading system for chronic tears. That's called Palmar 2. What's an A? Well, in a Palmar 2, you've got a long ulna that causes abutment. It drives against the TFC. It thins the TFC. So first sign, 2A, thinning. Maybe a better color. So thinning A. B, chondromalacia. Of what? Lunate and ulna. C, TFC tear, usually right there. D, LT ligament failure. Don't have it. So D would be LT. And E would be generalized arthritis. So those are the 5 stages of chronic TFC degeneration with abutment syndrome. Now that I've suitably entertained you and you have come up with a diagnosis, you might want to try the following maneuvers. It's well circumscribed. Agreed? It's round to oval. Agreed? Well, maybe not. Yeah, it is. How about the internal character of it? It's got a little bit of heterogeneity associated with it. T2 signal, not PD signal, not stir signal, not special, not spare, T2. It's white, which means it is very myxoid, mucoid, water-containing, high cytoplasmic to nuclear ratio. Automatically. That's good. Because a lot of bad tumors are packed with cells and solid, like medulloblastoma. So that's a good sign. Invasion of surrounding tissues? No. Let's go to the long axis to see if we can connect it to anything. Oh, it's not so round in the sagittal projection. What could we connect it to? A vein? It would be a varix. An artery? It would be an aneurysm. A nerve? It would be a nerve tumor. And we are connecting it to a nerve, the median nerve. There's the tail. So the diagnosis is simple. It's a median nerve schwannoma. How do you know it's a schwannoma? Because 95% of all peripheral solitary nerve sheath tumors are schwannomas, not neurofibromas. So you can guess. Also, schwannomas are brighter. They're smoother. Does it matter? Matters. Because neurofibromas are often unresectable. They involve the nerve intrinsically. Schwannomas can be peeled right off of the nerve very easily. So a surgeon is much more apt to go in and take this out and less enthusiastic about going in after a neurofibroma. Neurofibromas tend to be more disorganized, and there's usually not just one, and may be associated with NF1, autosomal dominant, the most common phacomatoses. So isolated peripheral nerve sheath tumor, going to be a schwannoma. Anybody have any other thoughts on this case? She's a beauty. Next.